It gives me great pleasure to introduce Dr. Christopher Kovacs. He is University Research Professor and Professor of Medicine, Obstetrics and Gynecology, and Biomedical Sciences at Memorial University in Newfoundland. He trained at Queen's University, the University of Alberta, Harvard Medical School, Mass General, and the University of Melbourne. Well-traveled. His practice involves osteoporosis and general endocrine, and we're very excited to have him speak about something that is becoming a big concern for me as individuals with rare bone disease get pregnant. So calcium and bone metabolism during pregnancy and lactation, and the impact on disorders of bone and mineral metabolism. Very timely, and thank you so very much for joining us today. One quick note, do be sure to stay on the call because he does have a bunch of cases to tantalize us with after his talk. All righty, so thank you again for being with us, Dr. Kovacs.
Well, thank you for the invitation and for that lovely introduction. And I'm always pleased to talk about this subject, which is of pet and career interest of mine. Now, I just got to make sure the slides are moving for me. There we go. All right, and you see some disclosures there, but none are really relevant to this presentation. So I'll be talking about the adaptations in mineral and bone metabolism that happen during pregnancy and lactation and the impact that they in turn can have on diagnosis and management of various metabolic bone disease conditions, including osteoporosis. And to start off with pregnancy, just first the consideration that it's a time when the mother needs to provide a substantial amount of mineral to her developing fetus. And you can see the amounts of calcium, phosphorus, and magnesium there. These don't gradually go across the placenta during the whole of pregnancy, but instead about 80% rapidly goes in the third trimester. And in particular, you can see that the rate of calcium is about 60 milligrams a day at week 24, but between 300 to 350 milligrams per day in the last 6 weeks. And you might think, well, so what? That's just a Tums. But we have to also consider what is the typical calcium intake for a reproductive age woman. And using NHANES data as well as Health Canada data, we see that the 50th percentile of calcium intake is between about 800 to 1,000 milligrams a day, with variations by ethnicity and age, younger women tending not to consume as much. And typically, net calcium absorption is about 25% of intake. So 800 to 1,000 milligrams translates into 200 to 250 milligrams total intake. Clearly, that's not enough to support the 350 milligrams a day that the fetus needs during the third trimester, the last part of it. And so that's the 50th percentile. Many women are going to be below that intake. Is this an interval in which women need to be taking in much more calcium? Well, it turns out that if they're taking adequate calcium, they don't need to consume any more because of the adaptations that are invoked during pregnancy. And in particular, what we see with studies using stable isotopes of calcium, that the absorption efficiency of calcium goes up at least twofold, beginning in the first trimester and maintained throughout pregnancy. And this is accompanied by typically a doubling or more in the total calcitriol level with a likely elevated free calcitriol throughout all of pregnancy. And some careful calcium balance studies have shown that by mid-pregnancy, most women are in a very positive calcium balance, suggesting that they may be storing in advance of the demands later in the third trimester. And most women, on average, will have hypercalciuria, so that they're tending to absorb more calcium through their gut than they actually need. So the kidneys are excreting the excess, and that's unfortunately contributing to a bit of risk of kidney stones during pregnancy. So this is the adaptation, but clearly if a woman isn't taking in enough calcium or has an impairment of absorption, then she's got to get it from somewhere because the fetus and placenta are going to draw it, and it's going to come from her bones. And so during pregnancy, we see a net increase of intestinal calcium absorption represented by the green arrow. facilitated in part by calcitriol, that rise that's coming from the maternal kidneys and very little from the placenta. But the placenta and is making placental lactogen, is making estradiol, and these have been shown in animal models to stimulate intestinal calcium absorption as well as also directly stimulated the 1-alpha hydroxylase. So there's a number of things that are going on which support that calcitriol is being stimulated by parathyroid hormone independent mechanisms, and that intestinal calcium absorption may also be stimulated by mechanisms independent of calcitriol itself. And so typically during pregnancy, well, one of the first findings is that the serum calcium falls. But that's because of a fall in the albumin. The albumin adjusted calcium and the ionized calcium stay normal. But the fall in the serum calcium often fools a clinician into thinking that something's wrong. Parathyroid hormone is low at a time when calcitriol is going up twofold or more. And already that should point to you that there's something different going on, because as an adult, if you don't have parathyroid hormone, you don't make calcitriol. But if you're pregnant, you make calcitriol without making parathyroid hormone. So something else is stimulating it. One of the things is parathyroid hormone-related protein, or PTHRP, that increases modestly but steadily across the trimesters. Estradiol is up 100-fold, placental lactogen, prolactin, other factors, all of these contributing to the alterations in mineral homeostasis and the doubling of intestinal calcium absorption. And on the right here, I've depicted women may or may not take in more calcium, but they've got this doubling of the efficiency of absorption, and that's what is providing most of the mineral content to the baby. There's been various estimates and also tests in mammals showing that most of the mineral in the baby's skeleton came through the mother's gut during pregnancy and not from her bones under normal circumstances. And you can see the kidneys are filtering the excess calcium, and so typically we see hypercalciuria during pregnancy. And the key points, the adaptation in pregnancy is increased intestinal calcium absorption, but if the mother isn't taking in enough calcium, she's going to borrow it from her skeleton with potential consequences. And as I alluded to here earlier, that increase in intestinal calcium absorption is driven in part by the increase in calcitriol, but we have data from animal models showing that there's also a similar increase that happens if you don't have calcitriol, if you don't have the vitamin D receptor, or if you're severely vitamin D deficient. Whether that applies to women isn't so clear because those kind of studies can't be done. But it does suggest that this adaptation in intestinal calcium absorption is so important that it's driven to occur independent of latitude, season, essentially vitamin D sufficiency. So with that in mind, this adaptation of increased intestinal calcium absorption and the rise in calcitriol, what effect does this have on various calcium and bone disorders? And in the following, I'm going to be briefly commenting about different conditions. I will be mentioning basically highlights because I want to skip through a number of different conditions, so it won't be detailed management advice and pathophysiology, but as I say, just some of the highlights. And to begin with primary hyperparathyroidism, hypercalcemia with parathyroid hormone adenoma, single or multiple stimulating it. One of the problems with primary hyperpara, first, is that clinicians have been fooled thinking it's gotten better in pregnancy due to the fall in total serum calcium. And I've seen individuals where indeed the clinicians have been reassuring that the condition is better when in fact you measure the ionizer or you do the calculated albumin adjusted and the patient's actually worse. The hypercalcemia has worsened. There's significant potential for maternal morbidity documented in many cases over the decades that this condition has been described. And it's because you've got the primary hyperpara and superimposed on that now the pregnancy-related increase in calcium absorption and the production of PTHRP that could be stimulating bone resorption as well. And so in severe cases, there could be such things as fractures, pancreatitis, and so on. That's not to say that every woman who has primary hyperparathyroidism in pregnancy is going to have this. Many cases have been mild and managed without intervention. But the fetus is particularly at risk because maternal hypercalcemia means increased flow of calcium across the placenta, and that tends to suppress the developing fetal parathyroids, leading to the baby being born with parathyroids that are asleep and neonatal hypocalcemia. But other risks have been documented in many case series with miscarriages and stillbirths and neonatal deaths. There have been many different systematic reviews of the published cases and looking at who was managed surgically versus medically. And in general, even with modern cases, the surgical management of the condition has tended to have a more favorable outcome for the mother and the baby. And so parathyroidectomy is generally advised for the second trimester. There's been a few cases that have been managed with cinacalcet, as well as fluids and diuretics and so on. But there have been cases where it's been possible to manage just with observation and then to deal with it in the postpartum phase. It's always a nervous and tricky situation. I'm often sought, my advice is often sought about these cases, and the clinicians are nervous about it. Should we go ahead in the second trimester with surgery? Should we wait? And you never really know what's going to happen until it does happen in the third trimester. With FHH, one of the key problems with it is that the calcium to creatinine ratio is not valid for diagnosis because they've got this absorptive hypercalciuria. And so you have to avoid being fooled into thinking it's primary hyperpara when it might be FHH. Because FHH is benign as an adult, it's benign in pregnancy. It doesn't seem to lead to severe hypercalcemia. It doesn't lead to maternal complications in any of the cases that I've seen. In fact, the only complication I've seen is a woman who was mistaken for primary hyperpara and was given a 3.5 gland parathyroidectomy. And it was when her hypercalcemia persisted and she became hypocalciuric postpartum that they realized she had FHH. And as with primary hyperpara, FHH carries similar risks for fetal morbidity and mortality. Again, that what we might think is mild hypercalcemia is enough to suppress the fetal parathyroids and potentially lead to neonatal hypocalcemia and hypoparathyroidism. So with FHH, it's, think of it, don't rely on the calcium creatinine ratio and be aware of the baby, especially after birth. Now, there's another condition that you may not be so familiar with. I've termed it pseudo-hyperparathyroidism, and that's started to appear in the literature over the last 10 years or so. This you might think of as sort of physiological hypercalcemia malignancy. It's basically PTHrP being produced as it should be, but perhaps in excess amounts, or that the individual's more susceptible to it. And you could get it from two sources in pregnancy. The breasts start making it early on. They're getting ready for lactation. So we have increasing amounts of PTHrP. And this causes hypercalcemia if there's too much, and it will persist postpartum, and especially if the woman breastfeeds. Whereas the placenta also makes PTHrP and it spills into the mother's circulation. That again can cause significant hypercalcemia in some women. And it will reverse very quickly with hours of delivery as soon as the placenta has been delivered. And it's difficult to control, the usual sort of things you do for hypercalcemia. And there have been a number of cases where, in fact, the woman received a reduction mammoplasty during pregnancy when the breasts were presumed to be the source, and that was the only way to control the condition. Now, hypoparathyroidism is particularly interesting because it invokes those adaptations and can be significantly improved. But it's also confounded by the normal fall in the unadjusted serum calcium. I've seen many instances, and there's indeed published case reports where the clinicians say, well, this patient with hypoparathyroidism got worse during pregnancy, and they have all the calcium and albumin values, and what was falling was the serum calcium, was the albumin and calcium. But when you adjust it, you can see that the adjusted value was maintained normal and in fact went above normal, despite the clinicians thinking that the calcium was low. So the doubling of the efficiency of intestinal calcium absorption, the increase in calcitriol that seems to still occur can lead to improvement. And so I'd say probably over half, maybe 2/3 of cases in the literature show that hypoparathyroidism improve. Women didn't need supplemental calcium or calcitriol or had needed only reduced doses. But on the other hand, there are reports in the literature where women got worse. And why? Maybe for some of them, the adaptations weren't as complete. But I've noticed with many of the ones where the individual seemed to get worse, where they truly were worse, not that the clinicians were fooled by the fall in the albumin, where they truly were worse, many of them presented pregnant mid-pregnancy and hadn't been managed well. And my feeling about them is that because they weren't adequately controlled prior to pregnancy, they probably missed that positive calcium balance by mid-pregnancy that normally happens. And so then they're really in a deficit fighting the placental demand in the third trimester. Now, if the mother is hypocalcemic or hypocalcemia worsens, that's bad for the fetus because the placenta and fetus will be trying to draw what they need, and the fetus may develop significant secondary hyperparathyroidism and resorbate skeleton, have fractures in utero, and then the baby's born, and it takes a while for those parathyroids to settle down, and so the baby can have hypercalcemia post-delivery. So the thing about hypopara is we want to maintain the maternal calcium in the normal range, trying to avoid any tendency towards hypocalcemia. And it means managing ad hoc, like following the patient along, adjusting the calcium and the calcitriol as needed up or down, depending on how the patient evolves. And of course, PTH replacement may become an option. I haven't seen as yet any cases that have been managed that way with PTH replacement during pregnancy. Just briefly about pseudohypopara. As with hypopara, again, there are numerous cases that clearly improved. The calcitriol rose, the supplemental calcitriol went down or was stopped, supplemental calcium was reduced, PTH declined substantially. All of these things pointing to the effects of intestinal calcium absorption is improved independent of parathyroid hormone. But as with hypopara, there are also cases that have gotten worse during pregnancy. And so, again, the management, I think, is paying close attention to these women and responding to the situation. Maybe they need reductions in the doses of calcium and calcitriol, their active vitamin D, or maybe they need increases, and depending on their individual situation and perhaps how well their body invokes those adaptations that normally happen during pregnancy. And then a condition that's more recently recognized in the last decade or so is the potential for severe hypercalcemia from 24-hydroxylase deficiency. These women can present with very severe, difficult to manage hypercalcemia. They have high calcitriol, but it's hard to distinguish from the normal high calcitriol of pregnancy. But in particular, they'll have low levels of 24-25 dihydroxyvitamin D to 25-hydroxyvitamin D, and ultimately genetic confirmation of inactivating mutations in CYP24A1, because they're either homozygous or compound heterozygous for inactivation of it. As adults, they may not know they have any problems. They'll have mild hypercalcemia that may not ever have been detected. They might have kidney stones, nephrocalcinosis, and so on, but many of them have not been known before, and the woman becomes pregnant and is subjected to what would normally be a greater than twofold increase in calcitriol, but it's unopposed by catabolism, and suddenly that increase is more severe. And we've been able to show in an animal model of this condition that, in fact, there is markedly increased intestinal calcium absorption, but not bone resorption. So this is hypercalcemia due to markedly increased intestinal calcium absorption. And these have been very challenging cases to treat, restricting the diet, using fluids and diuretics, oral glucocorticoids to try to suppress intestinal calcium absorption. And what hasn't yet been used in pregnancy, as far as I know, but have been used in non-pregnant individuals is rifampin to stimulate an alternate catabolic pathway, or one of the antifungals, the azoles, to inhibit CYP27B1, reduce the production of calcitriol. So these are very challenging cases to manage. X-linked hypophosphatemia, or XLH, that again there's always a mix of cases in the literature, and those have gotten better because calcitriol stimulates intestinal phosphate absorption as well as calcium. And so there are individuals who've gotten better during pregnancy, others who didn't or got worse. My main message about this is, one, don't use burosumab in pregnancy because it crosses the placenta and causes a severe phenotype in the babies of monkeys. And second, try to keep the maternal phosphorus in the normal range. And if it means adjusting oral phosphate and calcitriol. There aren't a lot of case reports about this. The last issue in pregnancy to mention, just briefly, because I'm going to come back to this in discussing lactation, is osteoporosis presenting during pregnancy. And typically it's vertebral crush fractures. How often this happens isn't so clear because back pain is so common. Many of the women who've presented with compression fractures have been overlooked for a time where they've been told, well, you're pregnant. What do you expect? Why not? Of course you've got back pain. And so unless systematic radiographs are done on a series of pregnant women, we're always going to be underestimating the frequency of this. And we usually don't know where they started from because these are otherwise healthy women who got pregnant and had no reason before to have a bone density done. And so I'll come back to this because I want to talk now about lactation. And you might think that whether evolution or design, that intestinal calcium absorption is upregulated in pregnancy to deliver the mineral to the baby, so just carry on during lactation. If you're a rodent, that's true, but humans, no. Humans, intestinal calcium absorption goes back to the pre-pregnant rate to supply mineral. Where's the calcium coming from? Neonates need about 200 milligrams of calcium a day through the first 6 months. Again, maternal intake is often not enough to meet that demand, but it doesn't matter because where the mineral is coming from, in this case, is from the mother's skeleton. And typically, women who breastfeed exclusively or near exclusively, meaning that most or all of the baby's nutrition comes from breast milk for an interval, if they go that way for 2 to 6 months, they'll lose up to 10% of the bone density in their lumbar spine. Now, as I say this, I know there may be somebody listening who's breastfeeding right now or recently did and who's horrified, but stay tuned. The message gets better, although it may sound horrifying at the moment. So a 5 to 10% loss in bone density of the lumbar spine, about half that or less at the total hip and so on. The kidneys are now contributing because renal calcium conservation starts occurring and hypocalciuria typically develops. But as I mentioned, intestinal calcium absorption is normal. So what's going on? Well, in a sense, the breasts become accessory parathyroid glands. They're making parathyroid hormone-related protein. They make it at very high amounts, and that PTHRP is spilling out in milk for one and doing something in the neonate, we presume, but it's spilling into the mother's circulation where it's stimulating bone resorption. And at the same time, the act of suckling and the pulses of high prolactin inhibit the reproductive axis, so we get low estradiol. And the combination of low estradiol, high PTHRP, probably other factors, account for this rapid stimulation of bone resorption that occurs. And so there's been many surveys of reproductive age women, observational studies, taking them at the time of delivery with bone density or beforehand. This is one example where women had bone density done before a planned pregnancy. And here they are post-delivery where there's a 1% difference over that interval. The upper level is women who didn't breastfeed, and you can see a small increase over the ensuing 12 months. Women who breastfed for less than 6 months, they were down about 6% at the 6-month time point and seeming to start to regain. And women who breastfed for up to 12 months, you can see they're down about 12% over that interval. So bone density loss happens. And I mentioned that it's independent of intake. This is hormonally programmed to occur by the production of PTHRP and the low estradiol. And various studies have demonstrated this. This is one example of a randomized clinical trial that took postpartum women, randomized them to a gram of calcium versus placebo. These are the women who didn't breastfeed, the bottle feeders. Here are the women who did breastfeed, and there's no significant difference between those who got calcium versus placebo because, again, this is hormonally programmed to occur. And so what happens during lactation? The serum calcium and ionized calcium are normal, but if there's serial measurements in the same women, they both rise slightly, probably because of the output, the efflux of calcium from the skeleton. Phosphate tends to increase and can actually exceed the normal range, again, probably because of the output from the skeleton. Parathyroid hormone is low, calcitriol is normal. PTHRP now achieves its highest levels that you'll have physiologically in an adult, and estradiol is low. Prolactin will be elevated initially and then elevated with each suckling episode. So the mineral intake, absorption are normal. Bone is being resorbed. The kidneys are reclaiming calcium avidly, leading to low urine calcium, and the calcium is going into the milk. With most of the calcium content of breast milk or of any mammal's milk being taken from the maternal skeleton during the lactating interval and not from the intestines. So in lactation, the neonatal demand for mineral is based largely on the mother's skeleton due to low estradiol, high PTHRP. This is going to cause a temporary reduction in bone strength. Lose 5 to 10% of your lumbar spine bone density. You can predict the bone strength is going to decrease. But for most women, this happens silently with no consequences. Most women are unaware that this has happened. And as I mentioned already, I often have someone who's in the audience who's horrified about what I'm talking about, and until I get to the punchline later. So what effects does lactation then have on calcium and bone metabolism disorders? So with primary hyperpara, one of the things that can happen is if the woman has been observed during pregnancy, then she can have a potential hypercalcemic crisis in the early postpartum because suddenly the placenta is gone, the outflow of calcium is gone, but she's got this massively upregulated bone resorption, and the intestinal calcium resorption is still there. And now the breasts are, again, with the loss of the placenta is one of the stimuli for the breasts to start upregulating PTHRP even further to get ready for milk production. So there's a potential for a severe problem right then. But once breastfeeding starts, then it's an outflow of calcium, and that tends to lessen the degree of hypercalcemia. And certainly this is the time period to be thinking, okay, we've got through pregnancy, let's do those imaging studies and get this woman fixed, especially if she's planning another pregnancy. And also this is the interval to be thinking about looking at the baby. The baby may be born with an appropriate calcium, but may develop hypocalcemia and even tetany over the next 48 hours or so. With FHH, again, probably benign, and as with pregnancy, the calcium-creatinine ratio can't be relied upon because it goes in the other direction to be quite low, and it's going to happen in all women. So the calcium-creatinine ratio during lactation can't be used as a diagnostic criteria for FHH because pretty well all women would meet that criteria. So FHH during lactation seems to be benign. However, it hasn't been studied. I haven't seen any case reports of women followed with bone density over lactation. And what concerns me is that John Weissel-Mercy's group at Yale, they had done a number of different studies using different calcium receptor knockouts. And one of the models, well, basically, there's a long potential story there, but the calcium receptor is in the breast tissue. It's regulating the calcium content of milk, and it's regulating the PTHRP production. And when you make the equivalent of FHH, studying the effect within the breast, it leads to high PTHRP and increased bone loss during lactation. So does that apply to women with FHH? We don't know because no studies have looked at that. And as I mentioned with pregnancy, FHH can lead to the neonatal hypocalcemia, even when the neonate inherited FHH. And that's been clearly documented in some case reports. So the baby experienced too much calcium flow during pregnancy, parathyroids are suppressed, hypocalcemic, needs support, and then later might develop hypercalcemia as the parathyroids finally wake up. The pseudo-hyperparathyroidism I mentioned before, again, that can onset during lactation, and it's due to excess release of PTHRP from the breast. The typical management of excess bone resorption applies here with bisphosphonates, denosumab as issues, but basically it's weaning. You want to try to shut off the breasts. And there have been cases where this persisted even after weaning, and a reduction mammoplasty was again needed. With hypopara, I think this is possibly the most interesting aspect of all these adaptations, because hypoparathyroidism actually predicted PTHRP. Back in the 1950s, apart from hypercalcemia malignancy, one of the scenarios that predicted the presence of PTHRP was the fact that women with hypoparathyroidism became normal when breastfeeding. And it was hypothesized that the breasts were making something that was like parathyroid hormone. And in fact, they were. And so PTHRP, the high amount coming from the breast tissue spilling into the circulation with suckling, it will normalize mineral homeostasis in most women with hypopara. And if this isn't recognized, the women actually become hypercalcemic, and there have been life-threatening degrees of hypercalcemia because they don't need the calcium and calcitriol. And so with hypopara, the clinician has to be aware, okay, woman's going to breastfeed, let's keep an eye on her, start reducing the doses of supplemental calcium and calcitriol. And most are able to get off it altogether, and they don't need it again until somewhere around the time of weaning. But sometimes this production persists and they don't need it at all. I know of a woman who's some 6 years since her last lactation episode, and she feels that breastfeeding cured her hypopara, but it's not that parathyroid hormone came back, it's that she's got persistent release of PTHRP. With pseudohypopara, again, potential for improvement because of the release of PTHRP, but it's complicated because of the post-receptor resistance to both PTH and PTHRP. And there's been very few case reports for me to be able to really say for certain what we can expect. Is the condition going to be unchanged, improved, or worsened? And it's a matter of, in this, I think, of just playing it by ear, adjusting the calcium and calcitriol as needed to maintain normal calcium. With XLH, during breastfeeding, women tend to normalize their serum phosphorus. And again, likely because of the bone resorption that's happening, since serum phosphorus rises in normal breastfeeding women, it rises in women with XLH. But concerningly, there's been a couple of studies where the milk phosphorus content was examined, and it was 50% of normal. And so we have to be aware, women with XLH, their milk may not be sufficient in phosphate, and it was shown to improve with oral phosphate supplementation. So have to consider about continuing to supplement them. We have no data about burosumab. And of course, the baby may inherit XLH, and there's been examples of where the baby was hypophosphatemic, and it was probably a combination of both, that the baby was already starting to manifest the hypophosphatemia from the condition, as well as the fact that the baby was suckling milk that was low in phosphate. Now, I'll turn to the bigger topic now of osteoporosis during lactation and osteoporosis of pregnancy and lactation. Women can present with a cascade of crush fractures. There have been case reports of women with 6 to 10 or 12 crush fractures, all happening within a short interval. It's clear that this is bias of reporting. These are the more severe cases. And how common is it that a woman might have 1 or 2 fractures? We really don't know. And as I mentioned already, it tends to be overlooked because of back pain being so common during pregnancy and while breastfeeding and carrying a baby. And we generally don't know where these women started from, but it's likely that the bone loss that's inevitable during lactation has contributed to the fracture risk. In fact, when we look at pregnancy and lactation, about 80% of reproduction-associated fractures occur during lactation. So it's the final insult in that sense, that loss of bone density that couldn't be tolerated. There have been a couple of studies from Japan that used large databases to try to estimate the incidence, and they came up with very similar results, about 4.5 to 4.6 out of 10,000 pregnancies. So it's uncommon. Is that rare? But again, it's probably underreported. There've been over 1,000 cases in the literature, and I draw your attention to this meta-analysis that was published earlier this year from Stuart Ralston's group, and they confirmed some of the things that were already appreciated, that most occur in the first pregnancy, which suggests to me it's probably largely nutritional factors that were corrected because the recurrence rate is only about 12 to 15%. And 74% had breastfed for some interval, and most of them are vertebral compression fractures. And it's generally that the spine is what's lost. The spine is substantially lower than the bone density of the hips at baseline. I've got a list of various conditions that women with osteoporosis of pregnancy or lactation can present with. And I'm not going to go through it in detail, but I just want to emphasize, like, nutritional issues. If there's something affecting calcium intake or the efficiency of absorption or blocking it, such as phytate or malabsorptive disorders, these are going to likely lead to bone loss during pregnancy when normally bone mass should be maintained. If there's not enough calcium coming in, there has to be bone loss to meet the fetal demand during pregnancy. There's hormonal issues, as I've listed there. There's mechanical aspects that stress the skeleton during pregnancy, hormonal issues and pharmacological treatments prior to pregnancy that can have contributed to bone loss. Basically, overall thinking that, is there anything that compromised this woman's skeleton beforehand? And there's very few cases that have looked at screened for genetic contributions, but there have been overall probably about 10 to 15% of cases where it's been looked at. There's been possible pathogenic variants in some of the genes listed there that may be contributing to why this woman had increased fragility. But being a primipara, very common. Again, is that because many of these things are nutritional issues that led to bone loss during pregnancy prior to the inevitable bone loss of lactation? And when a woman fractures during lactation, of course, everything that I discussed on the previous few slides about pregnancy applies. And then you've got the physiological bone loss. In some women, maybe it's more than normal. If a woman breastfeeds twins, she's going to lose more bone mass than nursing a singleton because the bone loss correlates with the milk output. So overall, osteoporosis in association with reproduction, it can happen in a woman whose skeleton is normal prior to pregnancy, and then she lost during pregnancy, lost during lactation, lost more than expected due to a combination of things. Or maybe her skeleton was abnormal prior to pregnancy, and just the normal loss expected during lactation was enough to precipitate fractures. And sometimes we can figure this out, and other times we don't know, again, because of the lack of pre-pregnancy data. But the punchline and the good news, and if there's anyone in the audience who's been worried about what I've been saying, is that post-weaning, the skeleton normally recovers. And in healthy women who, in those observational studies, they breastfeed for 6 to 12 months, and then within 6 to 12 months post-weaning, their bone density and presumed bone strength goes back to where it was. There have been a couple of longitudinal studies that looked at FRCPC, and there's been evidence of persistent microarchitectural changes, some loss of trabeculae that persist, which suggests permanent damage from lactating. However, when we look epidemiologically, both prospective and retrospective studies, there's been more than 6 dozen now that have shown that lactation and parity too, but are neutral or protective against low bone density, osteoporosis, or fractures in the long run. So this loss happens, the skeleton goes back to normal such that parity and lactation aren't risk factors for osteoporosis. Of course, there's been a few studies that have suggested otherwise, but the bulk of them, as I say, more than 6 dozen studies reassure us that this change is healthy in the long run. And just a couple of short examples, you see the loss happening by 6 months, recovering in this case by about 6 months, or a study here that randomized women to calcium supplementation or not, and compared to bottle feeding women, and the women who were lactating, if they got a calcium supplement, they lost about 4% of their lumbar spine by 6 months, as did the women with and without calcium supplementation, while the women who were bottle feeding had a non-significant gain. By 12 months post-weaning, you see everybody's up 2% from baseline, whether they lactated and took calcium or not, or whether they bottle fed. So the loss happened in the lactating women independent of calcium intake because it's hormonally programmed, and the recovery happened to the same degree independent of calcium intake. And just as women who are healthy lactating will recover, so too women who fracture during pregnancy or lactation experience spontaneous recovery afterwards. And so then that begs the question, should we be treating these individuals or not? And I want to explore this over the next few minutes. Individual case reports and case series, women who just get calcium and vitamin D, what I call spontaneous recovery, they will increase their bone density 10 to 20% over the ensuing 12 to 18 months. Pharmacotherapy, and you see the list there, everything you think of for treating osteoporosis has been used, and the reported increases in bone density on the order of 10 to 30% over 12 to 18 months. Is one better than the other? There are no randomized trials comparing pharmacotherapy to spontaneous recovery, and there's a bias there because just about every report that used a pharmacological agent assumed all the increase was due to the pharmacotherapy, not realizing that there would be an increase anyway just with the post-weaning. There's one example of a study in the UK. This is spontaneous recovery. This is one of the first to report this. And spontaneous recovery in women who had fractured, 13 cases. The trouble with this, the data, you can't really analyze it because there's just plots of excursions and Z-scores, but roughly 1.5 standard deviations improved in the lumbar spine over the follow-up intervals. And then this one, looking at one site where they looked at individuals who had calcium vitamin D versus bisphosphonates versus teriparatide. Do you see any difference there? Again, the way it's presented, it's difficult to conclude anything from these curves, but certainly the impression is that everybody's improving regardless of what they received. And then this small cohort from Stuart Ralston's group, they looked at calcium and vitamin D versus bisphosphonates versus teriparatide in 8, 6, and 2 women, and the changes in the lumbar spine, the femoral neck, the total hip, very similar. So is there an advantage of pharmacotherapy over spontaneous recovery? Hard to know with the available data. This study looked at teriparatide versus calcium and vitamin D, 15 versus 8 women, and they reported that pharmacotherapy with teriparatide led to a greater percentage increase in the lumbar spine compared to those who got calcium and vitamin D. Seems to favor teriparatide, except that the women on teriparatide had a bit lower bone density to start with. And when you look at where did everybody end up, I've highlighted the lumbar spine in blue on teriparatide versus spontaneous recovery, and the total hip on teriparatide versus spontaneous recovery. And do you see something favoring teriparatide? I don't think so. If anything, with the slight favoring non-significantly is to calcium and vitamin D. And perhaps the largest study, and what I find the most disappointing, is this single site in Germany that reported on 107 cases over a 10-year interval. And they described that twice as many fractures subsequently occurred in those who got pharmacotherapy, which would suggest that pharmacotherapy is harmful compared to spontaneous recovery. If you're getting twice as many fractures subsequently versus women who are just allowed to recover on calcium and vitamin D. But 107 cases, very promising, and this was their data in the paper. And there's 2 problems with this. One, again, you can't get any analysis out of that when there's plots of Z-scores. And the second problem, I hope you're all having a strong sense of deja vu, because I showed this to you a few minutes ago. This is actually data of spontaneous recovery from a group in the UK of 13 women, but this was published by the German group as if it was their own data on pharmacologically treated women, which it wasn't. I had a delayed deja vu when I realized what I was seeing, that this was a plagiarized figure that didn't represent at all what it was supposed to. And I wrote to Osteoporosis International, and there was a discussion with the editor, and they communicated with the authors and back and forth, and they created some more. They presented a slide, and we said it wasn't good enough. They presented another slide, it wasn't good enough. And there were 3 or 4 iterations with increasing numbers of individuals in the graphs each time. And they came up with this, which is the lumbar spine change in on calcium versus parathyroid hormone versus bisphosphonate versus combination of parathyroid hormone and bisphosphonate of about 3/4 of the 107 women. Can you tell any difference there? I can't. And this was the total hip in about 2/3 of the women. And again, can you conclude anything about one therapy being better than the other? I can't. This is such a disappointing study. So you can see why I conclude we have lack of reliable comparative data to know, is pharmacotherapy better than spontaneous recovery, or are they the same? And I didn't mention the meta-analysis from Stuart Ralston's group, this one down below there. They looked at the few centers where they did compare women who had calcium vitamin D spontaneous recovery versus any form of pharmacotherapy. And there was no difference, but there were very few cases where that had been done at a single center. Now, if the study of 107 cases from Germany, if they're credible, then we have to be concerned that pharmacotherapy may lead to a weaker rather than stronger bone. We really need better trials. So I recommend for osteoporosis happening in association with pregnancy or lactation, I recommend conservative management, optimize calcium and vitamin D intake, overall nutrition, get them mobilized, do the practical things I've listed there, and give them 12 to 18 months, see where their bone density is, and decide then how much have they improved? Are you happy where they are? And if not, maybe give them pharmacotherapy. I don't like, well, you shouldn't give pharmacotherapy when they're breastfeeding because they're still going to be losing bone. And since they're going to gain 10 to 20% anyway, why not wait and see what is achieved before giving pharmacotherapy? And since anti-resorptives interfere with anabolics, if we give an anti-resorptive, would we interfere with the natural recovery? And if they're weaning, the cause of bone loss is gone. So why treat with something that stops bone loss when that cause is absent? And if we give an anabolic, are we going to find that just as in with postmenopausal women, that we have to treat with an anti-resorptive, or the anabolic effect is the gain in bone is gone in 18 months? And of course, these are reproductive age women. So even though they've fractured, their overall fracture risk should be low. And anything we give is off label with all of the problems. And I especially draw your attention to denosumab. If it's given to a woman who's pregnant, it has caused an osteopetrotic-like phenotype in mammalian fetuses, both of monkeys and rodents. So I have concerns about pharmacotherapy. So I suggest pharmacotherapy for more severe cases, or if at 12 to 18 months we've allowed for the spontaneous recovery and we're not happy with it. If we need pharmacotherapy, I think anabolics make sense. And only if anabolics can't be used or afforded, then use some anti-remodeling agents and expect that there would be some gain. But keep in mind, we've got no data right now suggesting that pharmacotherapy is better than spontaneous recovery, or that any form of pharmacotherapy is better than any other. But one last bit is maybe an anabolic leads to persistent gains in reproductive age women. There's been a couple of small studies, and this is one where in blue, they had women treated for a median of 15 months with teriparatide and then got no anti-resorptive treatment. And in red, those treated the same interval, and then they did get anti-resorptive treatment. And anti-resorptive could mean oral bisphosphonate, IV bisphosphonate, or denosumab. And you can see for a year, year and a half, it looks like their bone density increase is being maintained. So maybe an anabolic wouldn't need an anti-resorptive after it in a woman who presents with pregnancy lactation osteoporosis. So I'll stop there. I just want to emphasize a couple of points. Intestinal calcium resorption doubling during pregnancy, that's the mechanism for meeting the fetal demand. The skeleton being resorbed during lactation to provide most of the calcium content of milk. And as I've tried to elucidate in all these unfortunately short highlights, but that all of this can influence the presentation, the management of disorders of calcium bone metabolism, and you could be fooled into thinking things are worse or better if you don't even appreciate that the fall in serum calcium is not a true fall. And osteoporosis can present during pregnancy or lactation, with a woman having a fragile skeleton to begin with, or inadequate net absorption of calcium during pregnancy, increased absorption during lactation, other factors, and so on. So I'll stop there and be happy to take questions.
Thank you so very much. What an extraordinary presentation.